All right, well, welcome. We are here again with Sofia. I think most of you who are here live know her, but I'll do a little bit of an introduction to the topic. But I want to leave as much time as possible for you, Sofia, because I know you have tons of information as always. So we're here today to talk about the importance of the methylation cycle and the folate pathway. This is a big topic, and I'm really looking forward to seeing what you have to share with us on the topic tonight. This came to be sort of a conversation between the two of us, just how many questions we were getting about methylation and those tricky clients who just aren't getting better no matter what you do. All of the typical tools don't seem to work for them. And so you're going to be sharing tonight, Sofia, some other things that we can think about with methylation to be able to help those very tricky clients. So you're going to go through, as you've told us, the basics of methylation and its main pathways, what it is, how it functions in chronic diseases and the connections there, how methylation can be disturbed, epigenetic blockages, genetic SNPs, MTHFR, all of those topics we'll touch on. You're also going to go over the importance of the folate pathway, some symptoms and conditions that are associated with it, and lab testing and key genes that you need to understand, as well as the importance of diet, lifestyle, and nutrients in addressing disturbances of the folate pathway. And then lastly, the dangers of supplementing the wrong form of folate and over supplementing, especially in pregnancy. So for those of you who are here live, at the end of our call, we will be drawing for a free 1-hour Zoom consultation with Sofia. So hang out for that. We'll be doing that at the end of our call to thank all of you who have attended live. And then lastly, I guess I'll do just a quick introduction for those of you who aren't familiar with Sofia before we get into this talk about the importance of the methylation cycle and the folate pathway. So Sofia graduated from IHN in 2007 with first-class honors and had subsequent functional medicine training with pioneers in the field such as Dr. Robert Cass and Dr. Dietrich Klingart. And she has 15 years of clinical experience and over 13 years of teaching experience in the field. And that's how she splits her time, is between her private practice and mentoring new practitioners and teaching at IHN, where she does the Nutritional Symptomatology Part 2 course. She's also the founder of Sofia Elena Health and offers clinical nutrition consulting, functional testing, and complementary therapies such as reflexology, Reiki, and neuro-linguistic programming. And her clinical work is focused on degenerative conditions and autoimmune diseases. So methylation fits very nicely into that niche, which is, I assume, how you have so much knowledge and experience on the topic now. So thank you for being here, Sofia, and being willing to share this information. And from here, I'll turn it over to you to talk about all things methylation and folate.
First of all, that you invited me to do this, and I heard for some time that some of our network and nutritionist members were asking about methylation. And you know why you were saying that? That's why I know about methylation, because I work with chronic diseases. But let me tell you one big thing that maybe you don't know yet, that every one of your client has some methylation problems. You will not get anybody in front of you that does not have at least 1, 2, 3, 4, 5, 10 methylation problems. Anywhere into the vast, that methylation cycle that has so many pathways and so many enzymes and so many cofactors and so many glitches that can be happening there. And every one of your client has some methylation problems. And it's not necessarily by birth. It's not necessarily because there's an enzyme or a genetic makeup that makes them to have that methylation problem. Most of us have methylation problem because of nutrition. And even if you're a nutritionist, you still may have some problems there because you don't know exactly how to address some of the maybe times in your life when you need more of something than something else, right? So we are very much accustomed to, and I know I've been there, and I still do from time to time that, oh, is this, I'm going to give B complex. And even if there's a methylation problem, MTHFR, whatever else it is going to resolve the problem. You know what? is going to make it worse sometimes, because if you don't know exactly which glitches and what problem it is, that B complex is not going to work for everybody, or it's going to work for some time. And then unfortunately, is going to be totally tanking down, getting worse than they were before when they saw you, right? And they're going to call you and going to say, oh, it's not working, the protocol is not working anymore. And I know that I've done that myself 2 years ago. And I'm like, listen, if the protocol has worked for 2 months or 2 weeks or 3 weeks, it's going to work for, it's something else. You've done something. So you blame your client that it's something else happening, that it's not your protocol. Well, in the meantime, they may be over methylated and they're going on the other side of the curve, the other side of the, you know, you can imagine that supplementation like a bell curve, right? So you made them better for like 2 weeks, 3 weeks, maybe a month, maybe 2 months, and then they went on the other side, like tanked down. They went to where they were before. So this is kind of what how I wanted to think about methylation, right? So thinking even about all the degenerative diseases, and not only about the fact that Canada, unfortunately, is number 30 from developed countries in mortality of the newborns, right? Not newborns, of the infants, like 1 year old, right? Up to 1 year old, from birth to up to 1 year old. So what is like from the whole spectrum, from birth to death, practically all these people who have all kind of issues, what is really common? It's impaired detoxification, it's high oxidative stress, it's mitochondrial problems and cell membrane problems. All of these are, generally speaking, you will see in to some degree in each one of your clients. And what all of these have as cause, an underlying cause, it's methylation, right? So this is why we're talking about today. So I'm just going to go right into the slides. I will share the screens. The screen, not the screens, I have only one. Okay, so do the slideshow. There you go. So today already you were told by Veronica what we're going to talk about, so I'm just going to bypass this particular first slide. So let's talk about what is methylation. And methylation is something very simple, but very complicated at the same time, right? So what we call methylation is literally addition of a single carbon group with 3 more hydrogen atoms. So this is a methyl group. So this is one example, or a very simple example that actually it's not so simple because it's part of a RNA and DNA. From uracil to thymine, you just add there, instead of that hydrogen, you add that carbon with 3 hydrogens, and from here to here, you have completely different function practically. So what are the functions of methylation? What does the methylation do actually? And by the way, that addition
sorry to jump in, Sofia. I think you're meaning to change the slides, but we're still on the first one, what you will learn about today.
Oh. You know what? I open up a little bit of a glitch. Are they going around? Yeah.
Yes,
are they
beautiful.
Super. Sorry about that. Okay. So I'm gonna just make it. I could have understood I'm not on the right one because they move differently. Okay. In the Zoom, for everybody in Zoom, if you don't have a PDF, if it's just a PowerPoint presentation, it's not moving. The slides are not moving. This is something new actually with Zoom. Okay, so functions of methylation, what are they? Gene expression and regulation, turning on and off genes. So pretty important, right? Detoxification, process chemicals, endogenous and xenobiotic compounds, build and metabolize neurotransmitters. So every one of your clients who has depression, has anxiety, has everything from bipolar to whatever, has a serious methylation problem. Process hormones, right, like estrogen and so on, produces energy, this is how you produce CoQ10, carnitine, creatine, ATP. So we don't have even to take as a supplement if we reduce enough, and this is methylation. Produce protective coating for the nerves to the myelination. So what is multiple sclerosis? It's a serious methylation problem. Build and maintain cell membranes like phosphatidylcholine. build immune cells, natural killer cells, T cells. So every time you're thinking that you are sick, you hope that that methylation process is working, right? DNA and histone synthesis, if you don't know what histone is something to do with structural support of the chromosomes, and it's important in gene expression and regulation. So it's really the most important functions, I would say, in our body are linked to methylation. So how is your typical client with methylation issues look like? And some of them are serious. Some of them are, you would not know that, oh, you would not think that it's a methylation problem. So some of the worst symptoms are sick most of the time. Allergies, intolerances from food to environment, low intolerance to chemical exposure. Some people are so bad that they just bypass somebody that, wears perfume and they just, totally lose it. Signs of high toxicity, skin issues, headaches, migraines, nausea, insomnia, low energy, estrogen dominance, any hormone imbalance has a methylation problem. Teratogenicity, these are miscarriages, stillbirth, babies born with birth defects. And as I said, congenital malformations, deformation, and chromosomal abnormalities in children up to 1 year are the number one cause actually of death in children that are born alive up to 1 year. So again, this is not something that we can say that it's, it's like very, very small percentage. It's a huge percentage actually happening in Canada. Metabolic issues like obesity and others, chronic conditions from diabetes, cardiovascular disease. And I assume that most of your clients will come to you with some kind of chronic condition. All autoimmune conditions, arthritis, Hashimoto's, lupus, MS, just the whole line there, right? The whole bag. All neurological conditions, including anxiety, depression, autism, and so on. Autism is a big problem. Methylation, actually, one of the things that predisposes somebody to autism after vaccination, for instance, is methylation problem, and MTHFR, specifically one of the two or both of the MTHFR mutations. All cancers are methylation problem practically. So, okay, if everybody has a methylation problem, more or less, what disturbs that methylation? What does it mean to have a methylation problem? Why? Why do we have that? Genetic mutations for sure are one of the causes. So we call it polymorphism or SNPs. A SNPs, NSP or SNP comes from single nucleotide polymorphism. That's the long version of it. We are born with them, and we get from one of the parents or from the other parent, from both of them sometimes, right? And by the way, if you think that, to blame and to finger point your parents, don't, because each one of us, nobody's like it's in a, anatomy book or physiology book. We all have hundreds of different mutations, and it's normal to have. Now, what we see, unfortunately, is more and more mutations that we haven't seen before in the kids that are born these days. So we're either born with that, but it's not these genetic mutations sometimes are not even so important as the ones that we acquire or some other disturbances of methylation during our lifetime, right? So again, there are many other causes why this methylation is suppressed or it's faulty. I'm going to go through some of them. So polymorphism is the first one, right? Sometimes it's not even polymorphism, but a lack of substrate. And just for you to understand what substrate, it's one word that is used a lot, thrown a lot when we talk about methylation. Substrate is something which you methylate and you get something else. Like SAMe, for instance, it's a donor, it's a methyl donor. And it makes, from SAMe, we make neurotransmitters. So SAMe would be as one of those substrates. So even without polymorphism of these glitches from birth, you may have a problem, but just missing some of those substrates. Lack of cofactors. There's a lack of every literally reaction in the methylation cycle needs some cofactors. And the cofactors are usually vitamins, like methylcobalamin, zinc, B6, and minerals too, like zinc. So B6, magnesium, and so on. B6, by the way, a tip there, B6 is it's huge in the methylation cycle, appears many times. Exposure to toxins like chemicals, heavy metals, could be their mold, could be, parasites, could be candida and all that stuff. Internal toxins. And I just gave one example there, but there are many, right? So think about people who don't move their bowels. So if we think about people who have candida, only one of the 14, if I remember well, candida toxins that the candida produces acetaldehyde. That's one of the worst chemicals that actually is attacking the methylation cycle or dragging down the methylation cycle. Medications. And I'm going to talk a little bit about nitrous oxide today, just as an example of how bad that is. And you probably got that when you got, not probably for sure, when you got your wisdom teeth out. Well, some children have died from that. So I want to talk about this today, just to, caution there for some of you who have children, or for some of you who want to go through that or will go through that. Metformin is another one, and I have a slide with a lot more medication. There's like really, I can put probably 10 slides only on medication that impairs one part of the other one, methylation. Excessive nutrients. And so lack of nutrients and excessive nutrients or excessive substrates. And there are some examples here, which is, for instance, niacin, B3 in the form of niacin. We actually are, sometimes if methylation goes wrong, if you are super methylated, over methylating the client, then I always tell them, you know what, always have niacin at home. Why? Because if you start feeling crazy, literally, you feel like beating up your children or your spouse or whatever, whoever around, then take niacin, because niacin is stopping that, it's slowing down the methylation, right? Excess substrate as well. For instance, SAMI, you give somebody SAMI as and with a lot, probably some of you have done that already, right? So you have some clients or a client who is missing some neurotransmitters there. It's a little depressed. You heard the SAMI is working. Guess what? If you give too much SAMI or for too long SAMI, you're going to inhibit the whole methylation pathway. And then they really get depressed, right? So lack of sleep and restful sleep, that's another one. High stress, anxiety, habitual negative state of mind, wired and tired, weak adrenals, even hypothyroidism, it will slow down methylation in some spots. So let's talk about the nitrous oxide, and then I'm going to go through other examples. So a patient when is going major surgery or just, at the dentist, sometimes this is used as anesthesia. And I think a dentist, when you get the wisdom tooth out, they always use only the nitrous oxide. It's not nitric oxide, by the way, that's completely different. It's a nitrous oxide. So it really questions, there are quite a few papers, and this is just one of them in anesthesiology, a review in anesthesiology. It questions totally the routine of using the nitrous oxide anesthesia due to many sometimes serious side effects. Some of them are nausea and vomiting. Probably everybody had nausea, but post-operatory infection, impaired wound healing, neurological damage, and even death. Increase the risk of teratogenicity. So a woman who is pregnant, goes through that, it's always going to have a negative impact on the newborn or even a miscarriage. Increased plasma homocysteine concentration, which is high risk, means high risk of postoperative cardiovascular complication. You don't want to have that high homocysteine, not even for like a week high or a month, right? So that means cardiovascular disease practically. Other publications are talking about vitamin B12 deficiency resulting in myelopathy. So really demyelination of the nervous system, which is really the beginning of MS. Right, so paresthesia, myelopathy, subacute combined degeneration of the spinal cord. That spinal cord degeneration, many times it's for life, right? So it's something that you cannot really reverse that. Even after a single exposure in those with susceptibility to vitamin B12 deficiency, or actually with the MTHFR problem, a methylation problem from birth. Bone marrow suppression, psychosis, subacute combined degeneration of spinal cord, myelopathy, neuropathy, polyneuropathy, peripheral neuropathy have been reported with nitrous oxide use. So really, if you have to have one of those things, I would think that you should, I would push you actually verbally, obviously, to have all your genome tested. not only MTHFR. MTHFR, it's one of the many that can go wrong in methylation pathway, by the way. Everybody's talking about MTHFR. It's not even so important compared to others that can go wrong. And this is the methylation cycle. And it's actually much more complicated than this. I was looking for something that is a simplified version, because if I have, by the way, somebody in my family gifted to me a few years ago the whole methylation stuff, and actually has citric acid on it and so on. It's probably it's a quarter of my wall. It's a printout. It's a pretty cool printout, actually. So methylation, it's much more complicated. Is that why I'm talking? Because today we're going to talk a little bit about folate cycle, the first pathway in the methylation. That's where it starts. It all starts. If something goes wrong there, it goes wrong all the way down. The second one linked to that is the methionine cycle. And this one even has another cycle linked to this. This is not even here. SAMI, for instance, and all the neurotransmitters are not even here. It's part of this bacterian cycle. So it's another cycle. It's not even represented here. And even this one, the last cycle, where at the end of it, we make glutathione, this is a transsulfuration cycle. It's way more complicated. Literally, this one by itself takes about 2 pages, right? So if you blow it up, there are literally dozens and dozens of conversions there. Why pull this up? Because all of these things with colored, boxes, little boxes here, these are enzymes. And every one of these enzymes, by the way, they're not the only ones. For instance, the folate cycle, there are about 30 of them. It's not only 2 of them, but these are the most important ones that can go wrong. But each one of these enzymes can go wrong by genetic makeup, right? So born with some kind of glitch, like MTHFR, this is one of them. This is another MTHFR that actually, it's not only bacterian cycle, but it does something bad, even the folate cycle as well. And then you see that citric cycle is like totally linked to these as well. This is nitric oxide cycle. And there are many other cycles actually coming out of these cycles that are linked to that folate cycle to start with, and the whole methylation cycle. So in the workshop that is coming actually in May, I'm having a workshop, 2-day workshop, 2 Saturdays, one after another one. We're going to go literally through each one of these. I'm going to talk about symptoms. I'm going to talk about which glitches, which particular ones are important to talk about, or even to see in your test, in your genomic test, and what to do about them. Even how to supplement when you have to supplement, how to recognize if you're super supplementing or too much supplementing, right? So there's a very, very important discussions, but unless you go through each one of the pathways very, very detailed, you're not going to understand anything out of it, actually, right? So again, it's complicated, can be done, can be broken down as something that is more digestible. And this is my promise, it's going to be much more digestible than some of the courses that I took for many years about methylation, where I did not understand a thing. And then for another few years, actually, I started studying it piece by piece and to understand where is it going and what is it doing. So this one, it's a literally bird's eye view, a very, very high flying bird. It's like a very, very simplified methylation cycle that starts with that folate cycle. And by the way, I could not find anywhere in the medical literature something that says folate cycle, because folic acid is something, I'm going to talk at the end of this presentation, something that you don't want to have, you don't want even to think about it. So this is the folate cycle, not the folic acid cycle, and then the methionine, and then you have the transsulfuration pathway here. So why I pulled this one up, kind of looks more digestible to begin with, but also just to show that all these enzymes here, reductase, transferase, synthase, another synthase, right? Anything you know that already, if you practice that ACE, anything that ends with ACE, it's an enzyme. So any glitches that can go wrong with these, and by the way, there are much more in between. These are just a few of them. But also there are these cofactors that I talked about as causes of methylation problems. When they don't exist, they're not enough. So here, for instance, the B12 here, somewhere in between these two, it's actually, it's B2. B6, as I said, appears many times, actually appears at least about 20 times in the whole methylation cycle. So B6 is really, really important to have, and many times to take it as a supplement, and not necessarily be complex if you have the other ones, right? Even here, there's a lot of Bs that are here where we talk about neurotransmitters. It's going to be zinc, it's going to be magnesium. Actually, even here between methionine and SAD, you have to have enough magnesium. Otherwise, this is really going really, really slow. And the whole wheel is not turning. Whenever I talk even to my clients sometimes, your wheels are not turning. They just say the folate cycle, methionine cycle, they're just like two wheels that they have to go together. Anything here in this particular cycle, folate cycle, is slows down, is going to slow down the other wheel. And then nothing's going to happen here, practically. It's going to slow down the whole thing. And the other way around, it's anything in methionine slows down. Maybe you have a glitch here. Maybe you have a glitch here somewhere, or unfortunately here. If this homocysteine is not broken down, guess what? Cannot be taken up and be broken down by anything else. Yeah, it could be broken down kind of by betaine if you consume a lot of beets. But again, if you consume a lot of beets in the workshop, you're going to find out that it's not good either. Why? Because your body's always going to take the shortcut from homocysteine to methionine, and you're going to bypass this. So why is this so important for the homocysteine to be recycled through the use of folate B12 into methionine? Because if this is not happening, the left wheel of folic acid of the folate is not happening either. So these are some only very, very few just examples to show you that it's not as simple as like, okay, I'm going to give some methylfolate here, like folate in the methylated form, and everything is going to move fantastic. It's not. This one can be totally stalled. This folate cycle can be totally stalled by something completely different that's happening after that, right? Okay, so let's go to one carbon metabolism, it's called, right? The folate cycle, that first cycle. And I went back and forth, I think, for about 2 weeks about like, what am I to talk in the 1 hour, which part of the methylation? And I realized this after 2 weeks that really I cannot talk about any other part of the methylation because they're not going to understand anything. I have to start from the beginning, literally. The folate cycle is the one. So it's the main regulator of the methylation cycle. Folate, what's folate? Is it folic acid? No. Folate, it's a generic term for 150 different forms of food folates plus the synthetic folic acid. So folic acid does not exist in nature. So all of these, we call them folate. So what is the function of folate? Synthesis of nucleic acids and DNA production and repair and transport RNA. That's a key role in protein synthesis. So pretty important, producing RNA and repairing RNA. So think about, about some diseases there when DNA is not repaired. Single carbon metabolism for methylation. We talked about that. Neurotransmitter production, detoxification. It's not neurotransmitter production and breaking down has to happen, because if you build too much, you're going to become that person who cannot be peeled off the ceiling, right? You're going to go like literally out of control, like mentally talking, right? So again, both of them are happening in the methylation cycle. Now, folate is directly driving that, but this neurotransmitter production, detoxification happening after that in the next cycle, methionine cycle. Formation, also maturation of red blood cells, white blood cells, and platelet production too. So people who have problems, even anemia, by the way, right? Red blood cells are not doing well. They're not enough and so on. Even white blood cell and platelet problems, they do have a serious methylation problem. So it's not always just lack of iron. So folic acid. Is folic acid the same as folate? No, and no, and no. Folic acid is not folate. It's only one type of folate. It's the one non-natural, not found in nature, and the one that we should never ever use for anything. Folic acid may be used by some people if the body allows them to, after undergoing multiple conversions, but not by everybody. And I'm going to have quite a few, I think 3 slides talking only about folic acid, because it's so misunderstood even between practitioners. And there are a lot of practitioners, even naturopathic doctors, who are still using, for instance, folic acid for pregnancy and before pregnancy. And this is so absolutely so, I don't want to say the word, a bad word there, but it's absolutely like has to stop, and you have to know about it. Does it work to prevent neural tube defects like spina bifida and so on? Yes, there are many studies, and this is exactly why doctors are using it, and many naturopathic doctors are using it. But if you look at the negative effects of it, it's absolutely not, do not warrant its use. So you really have to use the methylated form. And I'm going to explain why. There are plenty in the last at least 20 years, there's plenty of science that tell us that you should never ever give folic acid. Actually, I don't know why it's on the market even. It shouldn't be. So folates that are clinically relevant that you have even to test. They have folic acid. Yeah, do we test that? I'm going to explain later why we want to test that in the blood. Folinic acid also. And sometimes we have to do that. I'm going to give you one example there. When you, it's going to be an example in another slide. It's coming actually. I'm going to tell you one example where folinic acid actually has to be used instead of hydrotetrafolate, the methylated folate. Why? Because of another glitch in another gene, other than MTHFR, by the way. So again, sometimes folinic acid you have to use as a practitioner. So this is how the chemically they look like. So it's very little chemically, very little difference between folic acid, which you should never ever put in our body through food or supplementation. We have that end there, nitrogen, and then you have tetramethylfolate, right? So you have the methyl group there, and in between them, actually, this should have been in between them. This is the folinic acid. And the folinic acid is kind of an offshoot of the main conversion from here to from folic acid to, or from folate from the food to methylated folate. Big difference between these three. Huge difference in how the body is using it. What is the body using it for? And it's only one little structure here different. So this is what. Let me see if I can move this on because I don't see my own slide. Okay, so this is how the folic acid and folate, dietary folate, all of those 150 different folates that we get from, mainly from, by the way, folates are in the animal food as well, like liver. It's a huge amount of folate in the liver. But most of it, we think folate when we think about greens, right? So all those are coming into here. But these are the steps, many steps, and these are all of these enzymes where, by the way, each one of them can have glitches. The DHFR, SHMT, the MTHFR, which this R should be right after F. It's a little bit of a glitch here. So all of these can have genetic mutations. And not only one, they have a few mutations. Also, in between them, you see there B6, B2, B12. So we need some, these are the cofactors, right? So there's a lot of energy consumed. There's a lot of substrates consumed. There are a lot of cofactors of vitamins, specifically in this particular part of the folate cycle, that are consumed in order to even the dietary folate to get it to the point where the body can use it. So this is where we use it, right? So this is the end of it. And this is that methyltetrahydrofolate that we use it to turn the wheel, to turn the next wheel of the methionine cycle, right? So where do these, I wrote here that some of the lists that probably I already said, conversion requires, all this conversion requires uncooked leafy greens. I'm going to talk a little bit about that, why only raw. Working enzymes, sometimes they're not working. Sometimes, by the way, I have a recent client that has a DHFR mutation, has a SHMT, both of them, because it's SHMT1 and 2, and has both of the MTHFR mutations. And I'm like, oh my God, I'm like scratching my head. Where do I start here, right? So in that particular case, I'm going to give, this is where it is, this particular 5-morph is the folinic acid. So if you have, just an example there, if you have a glitches at SHMT, you cannot just give the tetramethyl hydrofolate. Why? Because it's going to bypass all this stuff. And why is it so important? It's the purine synthesis, it's the DNA. So if you give somebody, say like, oh, it has all this crap there really in the, genetic stuff, and I'm just going to give some methylated B12, I'm just going to give some methylated folic acid, or just going to do all the methylated B complex, and it's going to be all fine. No, that it's going to be a big problem with the DNA. That particular person, it is literally not pushed from birth, I would say, towards having something like cancer or DNA problems, right? So again, that is one of the many examples. And you see here, it's going back and forth. So the beauty about giving somebody folinic acid is that it can go to purine formation, so DNA, but also can go very easy. It does go very easy actually into the end form of the methylated folate, right? So again, it's one example only that you're going to learn into that workshop. Receptors also, we have not only working enzyme and vitamins, but also we need receptors that are available. And that's where the last slides when they talk about folic acid, it's coming into place. Also, we have to transfer it into sites and transfer it into the cell, not only to sit on the receptors above the cell there or in the membrane. And for all that stuff, also even for the vitamins, we need stomach acid. So again, a lot of our clients don't have that, right? So again, it's not an easy, this is one of the beginning of the methylation, and a lot of things can go wrong here. So I mentioned some genes and SNPs there, right, that can go wrong. So these are all the SNPs that can, actually, they're not all. They're most important ones. They're not all. But these are the important ones to talk about, important ones to think about or to learn about in our workshop. So they have to do anything. I'm not going to read all of them. I'm just going to say a few words about the last two. So these the first ones have to do with transfer through the membrane and membrane protein regulation of the intracellular folate. This particular one, if you have this particular one, apoptosis is slowed down. So cancer risk is high. The other one, you can have megaloblastic anemia, needs B3 and so on. The other one needs magnesium. The other one, it means that if you have this particular one, you have a low substrate for MTHFR, so purine synthesis. And high uracil means high cancer too, by the way. So there's a lot of things that can go wrong into that one folate cycle. These ones are the most important one to talk about, and they are because they're most prevalent in the population worldwide. So the SHMT1 and 2, and the other one MTHFR that probably everybody heard about. Maybe you don't know what to do with it, but you heard about it. So high risk of cardiovascular disease, neurological diseases, cancers, and so on. So let's talk a little bit about the first one. Just to see, this is just that bit, and I already said that if this SHMT 1 or 2 has a problem, actually one does one thing, the 2 does another thing. I'm not going to go into details, but you do need folic acid in this particular case, right? And by the way, these two, MTHFR and SHMT, they're not, if you have a glitch, it's not totally blocked. There are some other ones later on that are totally blocked. But these ones are still happening for the body, for that particular person, but they're slowing down, right? They're slowing down the whole cycle. So how do you move them along with a lot of B6, for instance, on some folinic acid in this particular case? If we're talking about MTHFR, this is, I just wanted to put here, if you never heard about this heterozygous, homozygous, and so on, I'm not going to go into details, but just to show you how much of a loss of function you can have if you have this particular enzyme malfunction, right, from birth. So the percentage of loss of function is proportional to number of SNPs. Heterozygous means one copy from one parent. So either you have it from your mother or from your father. Homozygous means a copy of the gene from each parent, right? So if there are two mutations possible, that's C6, whatever, and then A1298C. So these things mean something, the numbers and the A and the C and so on. You're going to learn that in the workshop. It's very easy to understand that. If you have, for instance, first one heterozygous or from one parent, this particular one, it's obviously worse than the second one, but just look at the numbers, right? If you have this one only from one parent, you have 40% loss of function of that first methylation pathway. If you have the homozygous, means you have a copy of this particular one for both mother and father, 75 loss of function. That's pretty much stalled, almost stalled, right? The other one, if you have it heterozygous, is 20%, homozygous from both parents, 40%. Both mutations, you have it from one parent, you have one, and from the other parent, you have the other one, 40% loss of function. And somebody asked me actually in another webinar that I had, is it possible to have three of these? To have, for instance, homozygous, these two from both parents, and one heterozygous, the other one? Yes, it's possible. Can I have all four of them? Yes. And how much loss of function that is? Almost total loss of function. Right? It's a rare, and it's very possible you're not going to see that particular person in your office, because it's very possible that a person who has that has probably died in infancy. Right? So that's unfortunate. So what if you think like, you know what, I don't think I have that. I don't have any of those, you know, I don't have cancer, I don't have chronic fatigue syndrome. Chronic fatigue syndrome, by the way, it's a big methylation problem too. But I don't have any kind of chronic diseases. I don't have, you know, anxiety. I don't have, well, half of us present here, almost half of us will have that. 45% of the worldwide population has at least one copy of that MTHFR C677, this. So 45% of the population has 40% loss of function of that methylation first cycle, right? The first part of the cycle of methylation. Who is the most prone to that? And there's a lot of, by the way, here you have, it's a graph that literally you can see the whole world there. Mexicans are absolutely the worst when it comes to that. Huge amount of population has it, and actually it has it homozygous, meaning from both parents. So it's 75% loss of function. Italians, especially if they're coming, Italians, if you're born in Canada from Italian parents, they're coming from Italian descendants, you're still in the same boat, especially Campania, Sicily, Veneto, Northern China, Hispanics in general, and so on. So again, it's very, you have to know about this because it's very, very spread. When to test? Do I test all my clients? To be honest, I want everybody to be tested entire genome, not only MTHFR. And pay attention, some of my clients, they didn't know about the whole genome can be tested, and they tested MTHFR, they paid for MTHFR almost the same amount of money to pay for the whole thing. So it's really better to have the whole thing. By the way, there are many other more serious genetic makeup glitches than MTHFR that can go wrong. For sure, people who are have reaction to medication, methotrexate. I'm talking about this because I have some clients on that. This is a chemo drug, either used for chemotherapy for cancer, but many times it's used in small quantities actually for arthritis and some other autoimmune diseases, nitrous oxide and so on. So if anybody has, had that procedure, taking out their wisdom tooth and had like a horrible reaction, I know already they have an MTHFR problem, but I want to see what else they have. Recurrent blood clots, elevated homocysteine, cardiovascular, any cardiovascular disease, chronic cardiovascular disease will be probably linked to that. Recurrent miscarriages, ADD, ADHD, bipolar depression. For instance, right now I'm working with 3 ladies that I'm preparing them. They had miscarriages before. I'm preparing them for getting pregnant. I worked with 2 of them for over a year. The other one I just started working. I really pushed them to have the whole genome. I just got from one of them, and I'm really, really interested to see what she has there, because you really can help way beyond what you know already to help for not not only not having miscarriages, but to have an absolutely, completely healthy child at birth and after that. So when you talk about testing, other than the genome testing, 23andMe, and which is kind of a big question mark, who they give the information to, who they share it to, and so on. Ancestry DNA, that's another one you can do it with. It seems that they don't share the information with whoever, a third party, fourth party, and so on. But above that, what kind of blood testing can we do? I really want every one of my clients to do these blood tests. And this is something published in PubMed, and it's pretty good in identifying 3 particular things there. Serum folate, which is just the whole folate, red blood cell folate, RBC folate is called, and that's exactly how it should be written on a requisition, plasma homocysteine as the primary folate biomarkers. So the serum folate includes everything. Synthetic folate that maybe you ate yesterday at, I don't know, you went out and eat with your spouse in a restaurant, and maybe you're taking the, folic acid without knowing that it's really bad for you, right? Maybe you're drinking that, I don't know, in everything. By the way, folic acid is by law, has to be put, folic acid, synthetic form, has to be put in 38 different countries in the world. Canada is one of them. It's pretty bad. So a lot of us do have that. And unfortunately, we have that circulating, just sitting there in the blood, not even used. And metabolized folic acid, that's the bad one. It's just sitting there and can be also presented in varying concentration in plasma. So yeah, serum folate is a good thing to have. So if you have serum folate, for instance, is high, if the blood comes high, does it make you have too much? No, it means probably to have a lot of folic acid just sitting there, like an UNFA, unmetabolized folic acid, right? So also the serum folate doesn't mean much, because that particular folate needs to be transferred and enter the cell. You don't know that serum folate will ever enter the cell. So just sitting there. RBC folate is a better indicator of the status of folate of the previous 3 or 4 months, and also B12 deficiency. Why? Because B12 is used in that methylation cycle for the folate to be pushed into the cell, right? So that's important to know. A tip, you always want to test RBC folate plus folic acid plus serum folate for RBC B12 at the same time. And it just pains me, like literally I'm going nuts when I see on my clients come, I put that on the paper. They ask their doctor to do that, and the doctor refuses to do it. The doctor just does B12, for instance, and then repeat asking, it does the next time is going to do the folate. And the next time is going to do RBC folate. You can't interpret them unless you have them the same time, taken the same draw, right? So that's very important. And pay attention as a practitioner. Maybe you had that. I had it happening for the last 2 years quite a lot. My clients, my male clients are not tested, and for folate, any folate, forget RBC, any folate. And the response from the doctor is like, you are not going to become pregnant. You don't need that. Like totally wrong, man. Men are methylating too, and you hope they're methylating. Plasma homocysteine also, it's a functional indicator of folate status, right? So that is always elevated when folate is deficient. Other biomarkers and serum folic acid, unmetabolized free folic acid. So that's a separate one. Some in Canada, some labs do not even do that. So specifically only folic acid extracted from that. Another one, the count lobe or hypersegmentation, is called a segments of the neutrophils. Very rare that you see that, but that will tell you right away that folate is low and it's not metabolized. Can be done in Canada as well. So, okay, how do we address? So we know we have a problem. We do testing, blood testing and so on, or by symptoms, we know they had a problem. What do we do about that disturbance? Well, first of all, you see there are any xenobiotics that are disturbing that cycle. So interaction with drugs are immense. The list is really huge. I gave you only some example: anticonvulsants, anti-sulfa drugs used in anti-inflammatory as an anti-inflammatory for bowel disease, like Crohn's and ulcerative colitis. Lifestyle. So these are all from this McNulty. It's a very, very good, actually, article, and it's a big name, actually, in nutrition, a doctor. Heavy lifestyle, like heavy alcohol consumption, smoking, are also linked to low folate status. Even any kind of alcohol consumption will lower the folate, right? So if you're not a good, folate eater there, greens and your liver, you're in trouble. I'm not going to go through the whole thing, but non-steroidal anti-inflammatory drugs, when they're used in high dosages and daily, for instance, aspirin and ibuprofen, a lot of people use that daily. A lot of people have, for instance, severe arthritis, other problems with pain, right? They will use them daily. Taking folic acid, which is a synthetic form, at the same time as the cholesterol, or any folate, by the way, at the same time as cholesterol-lowering agents, cholestyramine, which, by the way, it's used a lot in, and it's good. Actually, it's very good in taking out your the bile level, the bile duct level, taking out and preventing reabsorption of moles when you're doing the mole cleanse. That's what it's used, and it's pretty good in doing that, right? But again, that will decrease folate. Methotrexate, I said it already, it's a folate antagonist, like absolutely, totally eliminate that. Drugs used in cancer therapy, there are many of them other than methotrexate. Some antibiotics, some anti-malaria drugs, anti-pressure for high blood pressure medication. This one, it's a potassium sparing diuretic. Sulfa drugs for ulcerative colitis. Oral contraceptives. How many women you know they're still taking that crap, right? So again, containing high estrogen, that will lead to folate problems. So, okay, you start, other than looking at what do I consume there that will make my folate pathway, disturb it, you start from the beginning. You go with a comprehensive intake questionnaire from pre-conception. So if you're working with a child, even working with an adult, if they know, obviously, where did your mother work when she was pregnant? Where was she before that? And you have to do that many times, right? To understand where did it go wrong with the methylation, right? Symptoms, condition, medical procedures, medication, occupation, life stresses, traumas, current stress at work, home. So maybe you do that already. It's like a timeline of things, right? And you add some lines there with all these things. Possible exposure to toxins, like growing on a farm, growing near a farm. Maybe don't spray. You have organic, you're trying to do organic stuff, but maybe they spray. Swimming athletes, I work with a few of them, swimming 6 days a week, right? What is your postal code? Okay, where do you live? You live in Sarnia, or you live in, I don't know, maybe there is a pristine part of Alberta, Rocky Mountains maybe, right? Heavy metal toxicity as well. What's exposure? Diet, it's the next one they look at, right? So I'm not going to talk about all these in the workshop. We'll talk about this, but this is all the spots where the diet is absolutely, and then when you talk about neurotransmitters, kind of below that one too, diet is in every step of that, making neurotransmitters. So diet is pretty important and does interfere, negative or positive, to that in that methylation cycle. So in the diet, when we talk about, you think about substrates. And again, I told you what is a substrate. You don't know substrates. Maybe Sammy, I told you about it. But there are many other substrates you can take from food. So substrate means something that you methylate or donate some methyl group to something else, right? Where you want to go, where you want to get. But also very, very important, those cofactors, those vitamins and minerals that we were talking about a half an hour ago. Natural folates, particularly green vegetables, are unstable during cooking. And to be honest, I did not know about this only until some years ago when I studied very deeply methylation. And I had no clue that cooking that chart and cooking that, and it's not only cooking it in water and just storing the water. It's not about that. It's not that it's leaching into the water. It's about, it's unstable. It's a stable molecule. It just completely disappears, reduces the folate content of the food, and can reduce it to absolutely nothing. So it's really distressing that you have to consume all those plant foods. You can have to consume them raw, practically, or sprouted. because a lot of the natural folate, for instance, is in beans and grains, right? And even the cofactors like B6, most B6 is in grains. So you're not going to chew it raw, obviously, right? So you can sprout it, you can heat it just a very sprout and heat it at a very low temperature so you don't destroy all that stuff. A metabolic study, that's another thing that's happening, unfortunately. There's a lot of studies, actually, this is one of them, that show the bioavailability of food folates are only half, 50% relative to that of the synthetic folic acid. So that means if you have folic acid, if you eat food bought from somewhere that has folic acid added to it, and by the way, folic acid is added these days even into the orange juices, right? And to many other things. Many of your babies or our babies' foods, which is really tragic. I'm going to talk about that in a minute. So again, that means that folic acid has a much bigger, twice as bioavailable than the natural folates that we need, actually. So what does it mean? It means really that, it's on the next slide, it means really that we have a preference as bodies, as humans, to absorb the synthetic one versus the one that we really need. I wanted to put this on here just in case you wonder about the animal foods. So liver has very high concentration. Any kind of liver of any animal has the highest concentration of folate, way higher than any kind of greens, by the way, beans, legumes, and whatever. So there are some studies done, and this is a really good one that was published recently, actually. They showed four different cooking methods. Sous vide, and I had no clue what it is. I had to Google it. This is something that probably you're never going to apply because it's just vacuuming a plastic bag and putting it for 7 to 5 minutes, this particular one, into 60 degrees Celsius hot water. And I'm not going to do that. But steaming meat, and this particular was done with the chicken liver. Steaming meat 100 degrees Celsius, obviously all steam meat's 100 degrees Celsius for 30 minutes, did not differ significantly from the raw liver, which is good to know. But also they grilled it or cooked in a combi oven, whatever that is, or grilled it, resulted in much lower folate level than the raw one, but very high considerant compared to folate abundant plant foods. So again, really, if you're a vegan or vegetarian, maybe you want to think about it, like, where do you take the folate from? Suboptimal B vitamins. This is specifically only for folate pathway. There are way more for the whole methylation path, all the pathways. So again, B6, B2, B12 are the most important in the folate pathway. Again, grain-free diet, pay attention. Some of you may be on long, it's going on for years, maybe in some of you, paleo diet or autoimmune diet, keto diet, those have no grains. So really pay attention because you have to supplement. It's not even testing it. Do not even test it. I know you're low. You have to supplement B6 because most of the methylation from the beginning till the end is going to be slowed down. B2 sources, again, lots of it has in soy as well. It's pretty high in soy and tempeh. Eggs, liver, fish, and so on. Almonds have some. So generally speaking, meats and beef kidney, right? Mushrooms, also mussels and so on. B12, you know where those are, right? And again, most of the B12 is obviously in animal food. There is some in Swiss cheese and milk, obviously, as well, right? Lifestyle. So this is another reason why methylation can go wrong, but it can support that. So evaluate environmental exposure. Where did they work? How did they live? Water, food, conventional versus organic, personal care products, the whole list, right? I didn't even put the whole list here. Addictions, I mentioned that already. Workaholism, I put it here. And I was laughing when I was putting it in because that's where I am. Many times, right? I'm catching myself over and over again. Why? Nervous system and lowering stress, nervous system support is very important for not specifically for folate the first cycle, but for methylation cycle later on. There are two substrates and two genes, actually, COMT and MAL, that are necessary to produce and break down neurotransmitters. And those do not do well in stress. And again, If that particular methionine cycle is slowing down, it's going to slow down the first cycle, it's going to slow down the cycles after that as well. Detoxification support, and why we do that? Because anything that you detoxify in a different way, sauna, colonics, coffee enemas, dry skin, proper brushing, proper breathing, dry brushing, and so on, is not going to be a burden for your methylation, right? For the whole methylation cycle, it's normal. And the last one would be, what about supplementation? Here, for people who came to this today webinar to hear about what supplements to take, they have an MTHFR, another SNP. I will totally disappoint you because I'm not going to tell you about that. Why? Because it's really you're not treating the SNP. And this is something that has to be really ingrained into your brain forever. You cannot treat the SNP. I'm going to give you one example, right? For instance, a big example. I just said that a lot of the Italians, the majority of the Italians actually have the bad SNP there for MTHFR. They should, by theory, they should be the most depressed people in the world. And they should be on antidepressants more than them and I guess, and Mexicans, more than anybody else in the world. They're not. Actually, per capita, Canadians consume way more antidepressants than Italians. And I'm not talking about Italian descendants Canadians, right? Why? Because we don't eat our greens, and they do eat tons of greens. So they do have a folate status, and they're meats, by the way. You go to Greece, you go to Italy, there are not too many vegetarians or vegans, to be honest, right? And I know some of them because they're part of my family. So it's like, really. So you're not talking about the SNP here. You can have an MTHFR problem. If you have the 75% one slowing down, yeah, you have a problem. You have to treat it with some supplementation. If not, don't treat something that it's not a problem, right? Might have multivitamin and even B complex. It's not the best solution. It's not a best option. It's going to be different from person to person. You have to, every time you give a supplement, you have to understand what pathway you promote, what you're stimulating, and what you're inhibiting by giving that high dose of something, right? So for that, you have to know the whole methylation cycle, how it works. Evaluate how the person feels. At the very beginning, I explained about giving too much or for too long. Maybe the dosage is fine for a while, and then they go over the hump and they go down. Now that's the point where you're going to say, okay, you know what? That dosage is not good enough in this. It's too much for you. Go where you felt the best, not where I gave you the last one, right? Educate clients to observe the symptoms. It's going to come to that once you know methylation. So you're going to tell them, okay, in this morning, if you feel this, don't take that. Don't take that L-tyrosine or whatever it is, because you don't need it. When you feel down, you feel that don't want to get out of the bed and so on, take your tyrosine. And maybe you have to take it once or twice a week only, but not every day. Even the B complex, probably nobody will require every day that, maybe 3 times a week, maybe once in a while, and so on. Every one of your clients must have at home a bottle of B3 for emergency remedy. If you're super or over methylating, then niacin is used to slow down the methyl group. And in another webinar, somebody asked me, where can I find that? Carlson has a 50 milligram. That's a good dose to start with. Douglas Lab has 100 milligram. Many people do not need 100. You can open it up. If you need that, you're going to know. How do you know when to stop? They will know, because they're going to feel awesome after that, right? So if let's say if your 12-year-old, which was a sweet child until that point, starts beating you up, start being like really bad, then you know that you need B3 to give him or her. And the last stuff that I have here is for you about folic acid. And if there's one thing that you learned today, and you will always know, it's going to be this, hopefully. Folic acid is an anti-nutrient. So this is the synthetic form of folate. Causes significant harm to the unborn, but not only to unborn, to all of us if we use it. Reduced folates, which are the methylate folates, folinic acid, or the hydrofolate, hydrotetrafolate, are needed for DNA production, balanced methylation, support neurological development of a fetus and a baby, if we're talking about the babies, but our own one as adults as well. Folic acid binds preferably to folate binding proteins and folate receptors. So you're not going to have where to go with those natural folates, even if you take it as a supplementation. And remember what I just said 5 minutes ago, the natural folate, even as a methylated folinic acid or the methylated form, MTHFR, it has only 50% affinity when it tries to bind instead of the folic acid. So the folic acid is going to be preferred one. It's going to really bump there before that natural folate. Also observed folate, reduced folate compounds in milk of the mother, and reduction of absorption of folates by the intestinal mucosa of the neonates. And this is one of the reasons why this particular paper is saying that maybe this is one of the reasons why we have so many gastrointestinal problem with the babies, right? And if you work with babies or with kids, you know that that's really bad. Reduced bioavailability of the milk folate, a low concentration milk folate binding proteins compared to the pre-fortification reports, along with detectable appearance of unmetabolized folic acid in the milk of even unsupplemented mothers. So this is coming, that folic acid is coming from food practically, right? Fortified foods, which unfortunately Canada is one of the countries that pushes that. Also, two other things. Do not forget that the mother needs folate to methylate to prevent postpartum depression. All my clients who do have MTHFR issues, serious issues, that I work with them at least a year pre getting pregnant, and during pregnancy and after, they never ever went through postpartum depression, and theoretically that could have, right? So again, you really can prepare somebody not only to have a really beautiful child, but also not to go through that postpartum stuff. Heating breast milk, pay attention. A lot of women unfortunately are working these days, and they are unfortunately, and they have to, the pump the milk, and somebody else, the father or the grandmother, grandfather, whoever, it feeds that breast milk to the child later on in the day or the next day, right? You put in the fridge and so on. Pay attention that lowers folate by 25%, any kind of heating of the breast milk. And the last things there, this is something not only for the unborn or for the just born child or for the mother, also for every one of us. Folic acid supplementation does not reduce intracellular concentration of homocysteine. You probably, if you work with people with high homocysteine or people with cardiovascular disease, you know that you have to lower that right away. That's happening the second cycle, actually, of methylation pathway. So what does it mean? Folic acid supplementation is used even by naturopaths, unfortunately, to lower the homocysteine, and by doctors who know about homocysteine, how to lower it. And if you check the blood of the homocysteine, the serum homocysteine levels is going to go very nicely down. Guess what? The intracellular concentration is not going to go. So if you don't check something like an RBC homocysteine, you will never know. But studies show that folic acid is not something to use for lowering homocysteine. Why? Because it doesn't do anything. So on one level, you're happy that your blood work is like amazing and your doctor is happy. On the other, but you're literally dying from it, right? And nobody knows what you died from. During early embryogenesis, DNA methylation, which is the chief regulator of gene expression, is epigenetically programmed. So that epigenetics, what happens in the womb, it's very important. Any suboptimal methylation donor supply of the mother during pregnancy could alter DNA methylation and provide a ready explanation for a possible mechanism contributing to increased birth defects risk. And again, I mentioned that once, Canada is number 30 on the list, the bottom of the list, with infancy 0 to 1 year old death. And this is something that has to change. And we as practitioners really can do that. And I think it's absolutely the last slide that I have. Folic acid consumption by anybody induces hepatocyte degeneration. And this is published in American Journal of Clinical Nutrition. It's 2015. So it's not kind of yesterday published. It's published 8 years ago. So should be known in medical industry. The lipid disturbances alter membrane integrity arising from changes in phospholipid and lipid metabolism. So really, especially in people who are MTHFR deficient, this is absolutely tragic to use folic acid because you're going to kill their liver as well, right? Increase in overall cancer rates incidence associated with folic acid supplementation. This is a published work that is a systemic review or meta-analysis of several large randomized clinical trials of folic acid supplementation. So again, don't ever use it. Pregnant or not pregnant, it's not important. Nobody should use that. The findings suggest patients should not be taking folic acid supplementation while maintaining optimal folate status from natural sources. So I really hope that at least this is one of the important ideas that you are going away today. And as usual, I'm over 8 o'clock. I invite you to a more depth, discussion and learning about this methylation cycle and all the pathways and all the critical stuff. The workshop is May 6 and May 13, and you can register through the Institute of Holistic Nutrition. And again, I thank you very much for being here, listening to me and sticking with me. And thank you for inviting me to talk.
That was wonderful. We'll make sure we put up all that information about how to get in touch with IHN as well when we get the replay up. We have a few questions in the Q&A box already, but I want to invite anyone else who's still here live. If you have questions about anything that was shared, please do put those into the Q&A box now. Just before we do that, I'll quickly announce I put all of your names into a random generator, and Andrea, you have won the consult with Sofia. So I'll be sure as well after the call to connect the two of you by email so you can meet with her. And again, Sofia's offered that it could be for yourself to have some time with her, ask about your own health concerns, or it could be to consult about a client case. However you want to use that time, it's up to you. So congratulations on that.
And how are you going to put her in contact with me, or should I write my email here? Or?
No, I'll connect the two of you after by email. No problem.
Excellent.
All right, so questions we have here. Connie had asked, do you have a preferred DNA testing provider?
To be honest, I did mine with 23andMe. There's a lot lately. There's a lot of questions asked about, okay, like, we hear that they sold our data information, so on. By the time I did it some years ago. I remember that on the sheet there that I had to complete with all kind of information, there was one thing about there was one little box that you had to check yes or no. So specifically yes or no, if you want your data to be your genome to be used for scientific purposes. They didn't say who did it sell it to, pharma industry or whatever. And I said no. If that went anywhere, if it's still used, I have no clue because, yeah. So one thing about it is pay attention that USA does have a lot of laws against that, using without your consent and so on. Canada has nothing. Another one that, for instance, Dr. Ben Lynch, who I studied with, is using or is talking about 23andMe too, but also Ancestry DNA. So they came a long way, and they're checking. Also, another thing, if you're testing it just now, or if you say, talk to your client about it to test it, 23andMe for the past, 6-7 years, they took out a lot of the genes that they were testing before. They're not testing anymore. So I probably about a year ago, I just compared the two of them, and Ancestry DNA, it came on the top. So they kind of cost the same, I think the same.
Mm-hmm. It's very similar.
And depends also, that's another thing, depends what you do, you're going to get the raw data, right? So you have no clue what to do with the raw data. It's about a bunch of R's and S's and some numbers there. So you have to plug it in somewhere else. So where do you plug the data? If you're a practitioner already, Pure Encapsulation has, and I can never remember the name of it. Anybody can help me? Maybe,
I cannot remember.
Yeah,
I've used it myself, and I can't remember what it's called.
That's free. that's an okayish one. If you want something that it's paid, strategene, STRATE gene by Ben Lynch. So you have to pay for that. Also, Dr. I have it in front of me because I knew that it's going to be a question about that. Penny Kendall Reed. I studied some courses with her. She's a doctor in an ND, really good ND that does a lot of genetic stuff here in Toronto. So she has her own software, GeneRx, GeneRx. So there you can plug it in, but you have to pay for it also. But you can have an account as a practitioner. And as a practitioner, that's a pretty good one. By the way, I'm not paid by her to do advertising, but it's a pretty good one because it gives you possibility, even supplementation, if you know how to do it and so on. It gives you some indication what supplementation maybe you use, and you can even build up some protocols there and so on. But also it gives you stuff for weight loss, if there are any kind of glitches there for weight loss, and if for exercise or whatever cardiovascular disease. So they're very, very structured, right? So there's some other one. There's some other freebie ones, but generally speaking, the freebie ones, they don't give you so much. So it's really up to you. But other than Ancestry DNA and 23andMe, I heard that the other ones are not very good. They're not very, so yeah.
Okay. Nancy sent in a question here. It said, so what can nitrous oxide do to newborns when used on mothers during labor? And is there something we can do about it for the newborns?
Well, some newborns will not have a problem, but first of all, test yourself, right? So again, if you know that you have a problem or your husband has a problem, let's say it's your child, right? So if your husband has an MTHFR problem and you have an MTHFR problem, the baby will have it. So that's really a bad thing. So just ask the doctor not to use it. As simple as that, right? There are many other ways of doing it, by the way.
Yeah, it's you mentioned the dentists earlier with wisdom teeth. So I'm homozygous for the C677 and heterozygous for the A1298. And so when I was getting my wisdom teeth out, I had to go to 5 different surgeons to find someone who would do it without giving me nitrous and just use a local anesthetic before I could find someone. It was very challenging. They wanted me to take it. They wouldn't listen to the concerns. So it can be challenging to push back against that, even if you have the information.
But you know what? Nitrous oxide is not used in Europe. It's used for different reasons, but it's not used in dentistry. Here, it's not almost for sure. It's a conveniency.
Mm-hmm.
Nothing else. It's not needed, really. Local anesthesia is pretty good.
Mm-hmm. Yeah, and it went fine without and I didn't take the gas, and it went totally fine.
You were aware of that, right?
Yeah.
And you wouldn't have been aware if you wouldn't have done your genetic makeup.
Yeah, it's true. So we have another question here about you were mentioning about using niacin B3. So she's asking, when should we be taking that B3 for what type of symptoms?
Yeah. Well, for instance, if you're over-methylated, for instance, somebody, let's say, SAMI, right? You use SAMI for somebody who is depressed, or actually, I did put myself in over-methylation a few times, right? In the methionine cycle, in the second pathway, the methylation cycle, methionine pathway, we make neurotransmitters. So you can do a substrate, for instance, you can take tyrosine. So I do have a glitch there as well. I'm one of those people too. I don't have all your viewers, Veronica, although that MTHFR, but I have at least one of them. But I have some really serious one coming after that. And one of them is I don't make enough dopamine. So I know that when I wake up in the morning and I don't feel like going to teach that day or going to wake up for a client that is coming or whatever, I know that to take my L-tyrosine. I don't take it every day, but sometimes I'm just doing it without thinking about it, taking too much. So I'm going to start going nuts. I literally neurological problems, right? It's hyper, your anxiety, high anxiety, and so on. And that's when you take B3. Why? Because B3 is slowing down all the pathway. It's literally slowing down. And it's literally doing it in like minutes, right? So for over-methylation. Even you can do that, for instance, you can become anxious even by doing too much folate, by the way. Right? B12, rare, but too much folate. You can do that. They're literally. And I remember one of the courses I took some years ago, the teacher was giving an example of somebody who ended up in a psychiatric ward, because literally the doctor was increasing based on the blood work. And that's what it shows you, that the blood work is not the chief. And I teach that in the workshop. You have to watch the symptoms, not necessarily only the blood work. So if you give, for instance, 10 times or 5 times more, folate, let's say 5,000 micrograms, the 5 milligrams folate, just because the folate in the blood is low, you're going to supermethylate. And that particular person is going to start throwing things around. Is going to literally hit people and so on. And that's where B3 is going to come down in like 2 minutes. It's going to calm them down.
Nancy had mentioned in the chat as well, and she's a pharmacist in addition to being a nutritionist.
Cool.
And she mentioned folic acid 5 milligram is prescribed along with methotrexate.
And both of them, now you understand, Nancy, what it does. Both of them, they're slowing down methylation, right? And you're figuring out why some of the people end up in emergency room after that, right? And it's also think about women who want to become pregnant. For instance, women over 35, probably you know that already, they're considered geriatric, right? And I remember the first time when I heard that a few years ago, like seriously, I was like, one of my friends was like, the first pregnancy was 30 years old, and she said, like, she came crying to me, it's like, I'm a geriatric. What do you mean geriatric? Like, that's what he told me. So they're giving now, because there's stuff coming from Europe from a few years ago, that they should give 4 milligrams, 4,000 micrograms of folic acid. And I'm like, oh my God, like seriously, you're gonna totally have a child that either is not going to be born, unfortunately, or it's going to be a miscarriage, or it's going to be something really, really bad with that. And I do have some clients with, that they came to me with their child that had holes in the heart. That's something that we see a lot these days. And the cleft palate and all that stuff, like that's something that we've seen before. That's something even from low folate. But yeah, we see a lot of stuff from folic acid, unfortunately.
Another question here is asking, can you go back to the chemical structure and summarize methylation? When you first started your presentation, we got stuck and we missed that very first slide. Are you able to go back there and just review that really quickly?
If I did not, it's a PowerPoint. Let me not open the whole thing, the same PowerPoint. Okay. Okay, I think this is it. So let me just go. Okay. Okay. So methylation is just adding that 1 carbon group plus 3 hydrogen atoms. That's all what it is. And this is just one of the many examples, right? So in the methylation cycle, actually, we have those, for instance, SAMI. They're talking too much about SAMI now, but SAMI, right? Because we do that, sometimes supplement that. That is a methyl donor. So it's going to donate one of these in order to make all of these neurotransmitters that we make them after SAMI, right? So SAMI, we make it from that methionine, but that is going to be a donor of the methyl group for all the other ones coming after that, right? So this methyl group literally is donated all around to make whatever we need to make. That's all what it is. It's, again, simple.
Mm-hmm.
But we need a lot to do that.
While you have that up, there's one other question about the slides. One of the early slides said something about needing low stomach acid. Are you able to review that part? Because they're not understanding why low.
No, not low stomach acid, high stomach acid, low pH. So let's talk about, we have to have, where's that one? It's here. We have to have stomach. We have to have a low stomach pH, not low stomach acid. We have to have high stomach acid, low pH, right? The pH of the normal, if the stomach is working well, you have a pH about a 2. So we have to have because otherwise we cannot break down the leafy greens, we cannot break down the liver and so on, we cannot absorb the vitamins, we cannot break down even our supplements, right? So the only thing why I put it there, because a lot of people that you see as a client, they don't have enough hydrochloric acid. So that has to be supplemented at some point if that's the problem, that another problem that they have, right? So don't think only about methylation, think about what else is happening there. That's all what it is.
We have another question to clarify. Is B9, the methyl tetrahydrofolate, okay to supplement with, in your opinion?
Sorry, say again.
Is the methyl tetrahydrofolate form okay to supplement with, in your opinion?
Yeah, totally. The last one right here.
Yeah.
Yes. Yeah, totally. That's the one. For instance, you supplement with a B complex, active B complex. That active has to be there in the name, right? Active B complex from natural factors, active B complex from whatever, Genestra, right? Usually I buy one of the other ones, right? For my clients. So that has the B complex, has the methyl tetrahydrofolate, yes. But if you have this particular, that's what I'm saying, that you have to know the genome of the person you're treating, because if that particular person has the SHMT, this one, right, the serine hydroxy methyltransferase glitch, and there are two glitches there, then they cannot make this, right? And it's not only that this is important to go further to the next step of the methylation, but here what you're missing, purine synthesis and DNA synthesis. That's pretty important, right? So this is what I was saying, that, yeah, it's sometimes folinic acid. This one here is the one that we have to give on top of this one, maybe. But many times folinic acid is enough, because that one converts very easy actually in the methyl tetrahydrofolate, even with that without that particular, or with that particular glitch. Right? But yes, yeah, that's what you usually do. For instance, in the talking about the pregnant women or becoming pregnant, or you know, or somebody who prepares for pregnancy, all the good ones, NFH has a good pregnancy one, and you know, the multivitamins, they do have all the B vitamins are methylated, right? All of them, not only this one. So the easiest way to know if you're anybody who just started practicing, or maybe you're not practicing, yeah, you just started practicing because you are practitioners here. If you I don't know what I want to say. If you did not,
You said the easiest way.
yeah, this is the easiest way to do it, right? With B12, but no, sorry, with B complex. But sometimes you don't need that. And pay attention to that to people who have ulcerative colitis, people who have IBS, people who have horrible leaky gut, people who have intrinsic factor problem, right, by genetic, they are not going to absorb that B12. So again, you need the B12 for the second part, the second pathway, that methionine pathway, in order to turn the second wheel, to turn the first wheel. And so that's needed not only orally, then that B complex, that B12 and B complex is not going to be absorbed. You have to give it either they have to take it either injections or sublingual. So that's another aspect of methylation that some practitioners do not really pay attention to, right? And they say, like, wait a second. And my clients are always like, wait a second, like B12 is already here. Why do I take another one? It's too much. Well, it's not too much, because you have ulcerative colitis. You're not absorbing that, right? That's another thing.
All right, the last question that I have in here in the queue, it says, my son is 6 and has low iron, ferritin is at 17, and low B12 at 352, and he angers easily. Should I be looking into his methylation?
Totally. That poor little boy, it's suffering, and he does not know to tell you what he's suffering from. Yeah, totally.
It's tricky with kids, because they can't communicate a lot of those interoceptive feelings.
Yeah, and they're just angry, right? Because they don't feel well. And sometimes we are angry too when we don't feel well, right? We're like snippy, but they do not know how to communicate in another way that they don't feel well. But I would suggest, you and your husband actually do your genetic makeup. I don't think they do it for kids so small. I can't remember what is the cut to the minimum age what they do, but they don't do it for 6 years old for sure. And I'm not sure why.
I know I'll say I have many friends and colleagues who have sent in their kids' genome to 23andMe or Ancestry by just putting an alias and like a different birth date on the sample that they send in, so they can get the results back, see that raw data, and get past that age limit.
Okay, I thought it's something to do with not being able to, but I shouldn't be. No, it shouldn't be, because it's saliva, right? Yeah, interesting.
Jessica,
you just gave me an idea. I didn't think about that, but yes, thank you. Yeah, we do whatever we have to do.
Yeah, that's it. I did my kiddos, I think she was 3. When I found out I had some issues, I was like, okay, got to know what's going on with her too.
Okay, and you did it? Okay.
Yeah, and it was fine.
And she has yours. She has your stuff. Okay.
Yeah, she has. She's not as bad off as I am. My husband is less genetically challenged than I am, obviously. So she's got less of those methylation issues, but it's still something that for most of her life now we've had to be aware of, because it will come out in different symptoms, and to the point about anger, certain the one thing that you mentioned with the bees being in food. Nutritional yeast is often fortified with those synthetic bees. And so there's been a couple of occasions where she's had something with nutritional yeast in it, and she is just not herself, so angry and easily triggered. And it's those neurological type of symptoms. So even though we're generally very careful, one little thing, it is enough to cause those challenges when you've got that genetic stuff going on.
Pay attention also kids that are hurting themselves, scratching or whatever, doing all kind of things. That's a sign that something is wrong with the methylation there. And maybe B3 will help there, but not only that, but you have to address the whole methylation cycle. And that's a good idea to test that child like ASAP.
Jessica put in the chat, is it normal to feel overwhelmed looking at that big cycle diagram and feeling like anything could go wrong in that big diagram?
It's overwhelming. And it's still, to be honest, ladies, you know what? It's when I talked to Veronica actually some month ago, I think it was last year or whatever. It's like one, she asked me, like, do you want to talk about methylation? Because one thing that comes all the time is like people ask about methylation. It's like, yeah, sure. Methylation is important. And then when I started doing the slides and started working actually on the workshop, I'm like, what did I get into? Because really, for me, it's I've been studying stuff for like 17 years now. I've been studying with a lot of like big names in functional medicine, and even before the functional medicine was named functional medicine and so on. But and I still study, and I really, but not really believe. I'm certain that the one subject that was absolutely the hardest for me was methylation, because it's so vast. There's so many things can go wrong, right? But it just you don't have to be scared, and not have to be, if you know at least the basics of it. And today we did not talk only about maybe 10% of it, not even 10% of it, maybe 5% of it.
So I'll say to Jessica, if that is something that you think that you want to know more about, there is the workshop. You said May 6th and 13th are the 2 dates. Did I get that right?
Yeah, we moved it because we have a convocation, IHN convocation 29th, I believe. So we moved it a little bit down. Yeah, it's May. Yeah, we said it May 6th and May 13th. Yes.
Perfect. So if you think you need to know some more, there's the opportunity for that continuing ed too. I'll just kind of reiterate what you said. That's my experience as well. I knew a little bit about methylation from working with clients, but it really wasn't until I was recognizing this is a problem for me that I did this deep dive to be able to figure it out. And there's so much to know, and we're all going to keep learning more. And as there's more research that comes out, we'll be able to refine things further. So you just have to start somewhere.
Yeah, that's another thing, because it's so much research that comes out, right, all the time. And it's a lot of it is about methylation as well, right? And I hope that it's going to come, the day when folic acid is not going to be on the market anymore. I just hope, because there's so much information already in the science. It's so much published information, right? But it is still doing it. But at least you as practitioners, that you should never do that, right? And watch what else is your client taking, what is given by the doctor, because the doctor these days do give a lot of folic acid, right?
Yeah, good point. Well, I think that brings us to the end of our time together. Thank you, Sofia, for sharing all of this information. And congratulations again, Andrea, on winning that prize. I'll connect the two of you. And for anyone else, as I said, who's looking to continue learning about methylation and that folate cycle, you have the opportunity for that continuing ed in May.
Thank you. And Nancy, because you are a pharmacist, maybe you're going to spread information out there. Maybe you're just going to Google and find out all of those. There's so many of those studies that show actually how bad folic acid is. Maybe you're going to start in your own, if you're still working as a pharmacist, you're going to start in your own industry revolution there. You have that capacity to do that. Thank you so much, Veronica. And thank you everybody else that who came and listen to me. And Veronica, thank you.
All right. Thank you too. Have a great night, everyone. Take care. Bye-bye.